And this year, 2025, marks the 10-year anniversary of the Community Infectious Disease Emergency Response Team, or CIDER. And thank you all for being a part of it. It has been quite a journey. This team started after the United States had its first in the United States cases of viral hemorrhagic fever, or Ebola. And right now, there was just a Han recently. We're so happy to see that Hans are still coming out. There was a Han about Ebola in DRC. So this team is so critical and necessary for all of us to bring together all of our facilities and partners and skills and come together and be together to respond to whatever communicable disease emergency might come next. And we all know there's going to be a next one. So we're just really grateful that you're all here. And we've prepared a few presentations that I think will help us lay the groundwork for some of the big challenges that we face in the years ahead. And we haven't done another health vulnerability assessment since 2015, when back then this group determined that respiratory aerosolized transmissible diseases, such as MERS and SARS, were the highest risk. And so everyone who was engaged in this team was aware that something like COVID would be really bad. And we were meeting and connecting since the very beginning. And I'm just grateful that we were able to leverage all of us coming together to respond for COVID and so many other things. Multi-state hepatitis A, we've had invasive meningitis, we've had measles recently, and so many other things. So I am going to pass it on to Abby Wharton, who's going to present for us on wastewater surveillance and all the advances that are happening at CCAG to help us implement that programming.
What's the easiest way for me to share my slides?
Oh, if you go to Teams meeting, or if you want to send them?
I can go to the Teams.
Either way, yeah.
Yeah, if you join the Teams meeting, you should have sharing.
Okay, permissions. Yeah. And Abby has been amazing. She has taken us on tours of both the Boulder and Longmont wastewater facilities to meet with our partners there who run the labs and sustain all the testing for the wastewater surveillance program to be successful. So thank you, Abby.
Thanks for joining me on everything. 1 second.
We might let you.
Yeah. Perfect. Awesome. Yeah, the room audio will.
Yeah, I got it.
All right.
Sorry.
Oh, that's okay, Abby.
I don't know which one. There it is.
There you go.
There you are. Perfect. Kind of stand here, but
Yeah.
So-
Yeah, we can move the camera your way, I think.
you want me on the camera?
There's just a small room
We can also.
thing, so you're good.
Okay, I think works for me. So thank you, Carol, for inviting me to be here. I'm excited to talk about the Colorado Wastewater Surveillance Program. Like Carol said, my name is Abby Wharton, and I am the Wastewater Surveillance Coordinator for the program. If you've heard us talk about wastewater surveillance in the past, I promise we've changed since then. We've grown exponentially. So hopefully some of this will be new to you. Just as a quick overview of what wastewater surveillance is, just as a reminder, it's a method that tracks disease trends by monitoring infectious pathogens shed by individuals into wastewater systems. So people go to the bathroom, people wash their hands, they blow their nose, it goes down the drain, and we're able to figure out what kind of infectious pathogens are being shed by our communities. It can help us find early signs of disease in a community without needing to test each individual person, which is really awesome because, as we all know, clinical testing can be a little biased on who's getting it, who has the ability to get it. So this is really giving us a community overview so we can understand what's going on in that community level. So it's also very cost effective to do it this way. It can help healthcare providers and local public health agencies allocate resources. So if we start seeing increases of different pathogens in our wastewater, we know it's coming down the pipeline. We know we're going to start seeing it clinically. So it kind of gives us a little warning of what's going on and how we can best prepare ourselves. And wastewater surveillance can provide additional data that can inform us about community health. So we always recommend looking at our data on top of clinical data. So we can give a little lead time with our data. A couple days during the pandemic, we were seeing 7 to 10 days lead time before you would see it clinically. But we do recommend looking at it with the clinical data just to give a more holistic point of view of what's going on in public health. So a little bit about our program, just as a reference, we are a National Wastewater Surveillance System Center of Excellence. So very long way, we call it NEWS COE. Really what this means is we collaborate very closely with the CDC. So it's a partnership between CDPHE and the University of Denver that creates the Colorado Center of Excellence. So we really started our program fast in 2020. So CDPHE took over wastewater surveillance in August of 2020. And we started testing for COVID in wastewater. We've grown exponentially. We have a lot of innovation in our program. The CDC recognized that and went ahead and designated us as a center of excellence in August of 2022. What this means is that we work a lot with other state partners to talk about what works and what doesn't work, what we've learned. We talk about best practices for programs. We also do a lot of innovation for the CDC. So they send us, lab assays and we validate them. We are currently setting ourselves up to becoming a national sequencing center for the CDC News program. Our lab is incredible and they work very, very closely with the CDC. So we have a lot of support there. And the other thing I want to mention, because I am talking about the CDC right now, is that our funding is secure through 2029. We know that. I know. So we know it's secure. And the other weird thing is we have bipartisan approval on our system because it's cost effective, it's anonymous, it's at community level. So as of right now, Congress on both sides of the aisle, they like wastewater surveillance and they like what we're doing, which is awesome for us. So just wanted to mention that while I'm talking about the CDC.
So nice.
So I want to get into a little bit what our current program model looks like. But the reason I say current is because during the pandemic, we had a lot of utilities participating with us. We had 55 utilities to be exact, representing 65% of our population. So we had a lot of representation and they were submitting 2 samples a week, every single week, week over week, which is awesome. But that is a lot of samples. That's a lot of resources. That's a lot of time and staff that's needed for that, especially as we considered moving past the pandemic and into a further wastewater surveillance model and what that would look like. So we knew prior to everything happening with public health that public health funding wasn't forever. We were under COVID funding, and we knew that eventually we were going to see a cut in our funding. So we wanted to proactively get ahead of this and create a more sustainable program model, something that we can last through the years with our funding, but also something where we can start adding more pathogens and focusing more on like how we talk about wastewater surveillance data, how we use wastewater surveillance data. So it just really gives us a little more time and energy to put towards other things while also thinking about the fact that we need to be sustainable. And funnily enough, we had rolled out this model and about 3 months later, the CDC told everybody that they need to start right-sizing their programs. So we were ahead of the game. But we have in our Sentinel model, 10 utilities that serve the largest populations in their region. So we have Colorado can be broken up into 10 all hazard and emergency management regions. It's just a fancy way of breaking up the state. So we picked the largest populations, the utilities with the largest populations in those regions, and we compared it with the utilities that had smaller populations in those same regions. And what we found is that larger population utility represented those smaller ones. They had moderate to high correlation in like the viral concentration levels when looking at those smaller utilities compared to the large ones. We went ahead and added 3 additional utilities in the Denver metro area. That's just because it's such a large population that's so centralized in our state that we might see things radiate out from Denver. So we wanted to include them. And then we also included 4 utilities serving areas with high tourism. This would be because when we saw the correlations work really well with those smaller utilities, we weren't seeing it as well with high tourism areas. So like Aspen would have been represented by Grand Junction. Aspen and Grand Junction are very different populations. And the other piece here is that when we saw COVID the first time we saw it in Colorado, it was actually in Eagle County due to tourism. So we think that this might be where we would see those outbreaks first for things that are coming from out of state. Also, we moved down to this 20 utility model, but we still represent 50% of Colorado's population. So we decreased 2/3, but we still have that 50% versus 65. So we still have a really good population spread. And then one thing I will mention here is we haven't added it yet. We're in the process of adding it, but we're going to add one more utility in Fort Collins due to a difference in pathogens of what we're looking for now, and also just due to public feedback. People from Fort Collins really wanted Fort Collins represented in this program. So we were hearing a lot about that. And we did an evaluation and we were able to look at some data and use data to back up the decision to add Fort Collins. So that'll be in a couple weeks, that data should be available. So these are the different utilities by region. So Boulder County is obviously represented by Boulder, being the largest population in the area. So that would be the one that might interest you guys, but that's kind of what our model looks like right now. But we built such a great framework with our utilities, and it was such a unique partnership between our utilities that we didn't want to lose that framework, especially when it could become important if there were to be another pandemic or something that we're concerned about. So we created an emergency wastewater surveillance system. So anybody that was not invited to join the Sentinel surveillance model was invited to join the emergency model, and everybody switched over. We also were able to add a couple new utilities that have never participated with us before, which is super awesome. So the emergency model, I think it consists of about 40, but hopefully going up to 42 here soon, utilities that are ready to go if we need them. And what we would do is this would be in a short-term emergency wastewater surveillance system, and it would be activated when rapid public health response is needed to help monitor a pathogen spread across community and allows us to more effectively respond to outbreaks. So a couple examples here. Last year and now coming on to this year, we've been talking about HPAI and the concerns about HPAI. So we actually activated utilities where we started seeing flocks and herds that were infected with HPAI. We went ahead and activated those utilities, and when we surveyed them all year. So we made sure that the whole respiratory season, we had them submitting samples to us. Another example of this is we saw a measles case in Adams County, and we activated the Adams County utility that represented that measles case within 3 days. So this is a really quick turnaround process. It takes about 3 to 5 days to get them activated, but it's really nice because it gives us like a nimble practice, right? Like we can activate everybody and we'd have 60 plus utilities submitting to us, or we can activate 1 or 2 in certain areas if we're seeing things coming in. So this is a little what it looks like. I don't know why the emergency sites flash in and out, but this is the Sentinel sites are represented by the orange triangles, and then the emergency surveillance sites are those yellow circles. As you can see, we're very concentrated in the Front Range. It's because 80% of our population lives in the Front Range. So that makes sense as to why we have as many there. And you're probably also going to notice that we don't have a lot of representation in Eastern Colorado. That's just due to people being on septic systems versus going to a wastewater utility. We can't pick people up who are on septic systems. There's a high septic population in those areas. And then also those wastewater utilities tend to be pretty small. And we don't ever want to surveil a utility under 1,000 people because you kind of lose you're no longer anonymous when you're looking at under 1,000 people because we probably know who's contributing to that system. So this is, I think, the most exciting part. We started with COVID-19. That was what we did for a long time. That's what our program focused on. And then we knew that we wanted to expand the program. So we went ahead and added enterovirus D68, which that was in a partnership with the Children's Hospital in Denver. So they were seeing a year where there was a lot of EBD68 and acute flaccid myelitis in children. And they asked us, is this something you could pick up in wastewater? And so we looked at it and we decided we could. So we worked very closely with them to get clinical data from their model to validate our data every year. Then from there, we went ahead and added pan RSV and influenza A and B. Originally, when we added RSV, we looked at it as RSV A and B. And what we found and what other states found as well is this wasn't a good representation of what RSV was. Those assays, they were just not picking it up the way we wanted. So we moved to a pan RSV model, and we've seen really great data that correlates very well with the clinical data. And then with influenza A and B, we do subtype those out, and we go even further with influenza A. We subtype out to H subtypes. So we look at H1, H3, and H5 subtypes for influenza A. So H1, H3 obviously being our seasonal flu types, and then H5 is what we're looking for because of HBAI. And then from there, we went ahead and added Mpox clade 1 and clade 2. This was at the request of the CDC. They wanted to see Mpox data, just with the rising concerns. I will say we've not had any detections in Colorado of Mpox data, especially clade 1, but clade 2, we've really not seen any detections. Other states like California, they've seen a lot of detections. So far, like, we feel pretty good about that. I mean, we hope we don't have any detections of that. And then we have started piloting measles. Sure, that comes to no surprise. Obviously, that is the hot topic of the year. So we went ahead and piloted measles and West Nile virus starting in May of this year. And then what might interest you is we've also are currently piloting Candida auris and antimicrobial resistant genes. The stipulation with Candida auris and antimicrobial resistant genes is we are piloting this completely internally right now because we need to understand what the baseline level is. Of course, there's AMR in a community, so we need to understand what's that baseline level and what's concerning. And then Candida auris, the concern here is understanding biofilm in the sewer systems. How can biofilm affect Candida auris? So we're trying to give ourselves time to understand the data before we put it out there for everybody. So those are currently being piloted internally. But measles and West Nile virus, we just published on our internal dashboard that local public health and our utilities have access to. And around October, to be determined exact date, we plan to post measles on our public dashboard for the public to see. So it's kind of scary, but I think we're excited. So
You know what the timeline is going to be for the pilot of the AMR?
I don't. So we're working with other states who have been doing it for longer than us. Hawaii has been doing it for a lot longer than us. So we're all trying to understand the data together and figure out what it means. We're also working closely with our healthcare associated infections team to look at our data versus their clinical data that they're seeing. So it's hard to tell when we're going to be able to publish it. But I mean, we plan to at some point in time, and I know that's obviously of interest to everybody in this room. But yeah, we'll let you know on that one. We just, during COVID, we were, reacting and we were putting data out before we maybe fully understand it. And now we're trying, now that we have the time, we want to sit with things for a minute. Same with measles. We didn't post measles on our internal dashboard for months when we started. Now, if we had a detection of measles, we did reach out to local public health agencies and let them know, hey, there's measles in your sewer shed. You might want to get a little concerned about this, but yeah, we waited for months to put that out there just so we could understand it as a team. So you can find our data in 3 places. The public dashboard, which you all have access to, it's for the public. And we have the internal dashboard, which Carol and her team have access to. And then we have the CDC National Wastewater Surveillance System dashboard. So that posts for all the states and everybody that submits. So this is what our public dashboard looks like as of right now. So you can click on each of these individual pathogens and see, what's going on in the different sewer sheds. So each of them is interactive. Feel free and click, but we do show trends for SARS-CoV-2 and then detections for all the other pathogens. We were able to create a trend model for COVID because we've had so many years of COVID data. We're currently working on creating trend models for all of our new pathogens because every pathogen is a little different. Wastewater can be really complicated.
So I could share, I remember last year, I think it was with you, Kylie, and where we had a detection of flu that was kind of early. So we checked in with all of our IPs, like, have you seen it? And you had, but it was like travelers or something, like some people from out of town came in with flu and then they left, and so then it went away.
So then it was gone.
Yeah, so we were at least able to know what it was.
Yeah, it's interesting because we do pick up like people who just drop in on the population. And that's like one of the stipulations with measles data. It could be somebody moving through the area, but I will say, just as a little plug for and a success story for our team, we recently had a detection of measles in Mesa County. And it was incredibly high. So we were very alarmed. I mean, the viral concentration was crazy. And so we reached out to Mesa County and we actually were able to talk to them days before that case ever presented to them. And then they had a subsequent case about 5 days later. And we picked it up in the wastewater and we told them, you guys have measles. And then we've gotten a lot of compliments from them on our ability to be able to prepare them for that measles outbreak, and get them. We were a part of their HON that they sent out to let people know that we think there's more than one case here due to how much viral concentration there was. So that was like a success story for us. So continuing on with the public dashboard. So this is what it looks like. I pulled up Boulder County. So you can see the increasing or decreasing trend. I actually think you guys are increasing right now. I think this is an old screenshot for COVID. But it shows the sewer shed area. So you're able to see, if you wanted to, you could type in your zip code and it'll pull up your zip code and show you the closest sewer shed area to your zip code. And then, yeah, you can evaluate the trend. You can go through all of our different utilities and evaluate the trend there. This is under it. So you would be able to look at your viral concentration. For COVID, you'd also be able to look for flu, RSV, EBD68. We don't post Mpox viral concentrations. We haven't had any detections, but we just don't want to post that. We're not sure how the public would interpret it. So we want to make sure we're considering that. But yeah, you can see the viral concentrations. So, I mean, as you can see, right, we've been on a steady incline, which I don't know about you guys, but I know multiple people who have had COVID recently. So not super surprising to me. But yeah, you can look and see the different dates that the samples were submitted. You could check change the date period. You could go back to the beginning of the pandemic and look at this data compared to the beginning of the pandemic if you wanted. And then the detection categories for all of our pathogens that aren't COVID. This is taken from the CDC. They had created this framework for Mpox detections. So this is how we classify, if it's a persistent detection, just meaning that the virus was detected in more than 80% of the samples in the last 4 weeks. If there is a detection, it means the virus was detected in 1 to 80% of samples in the past 4 weeks, and the most recent detection needed to be within the last 2 weeks. No recent detection means it wasn't detected in the last 2 weeks, and then no recent data just means that the utility didn't submit enough data to us. I couldn't tell you the last time that's happened. Our utilities submit twice a week, every single week. So if you wanted to look at influenza A, so we have 2 tabs. You can click influenza A or influenza B. If you look at influenza A, you can see the subtypes. This is an old screenshot because the one right now is a little boring. We're kind of at the start of respiratory virus season, so I think we had maybe 1 detection of H1 subtype. So you can look and see if we've had any detections of H1, H3, or H5 in your sewer shed. And that can be really helpful when we're starting the respiratory virus season. So I wanted to talk a little bit about wastewater surveillance data applications for you all. So you can really take wastewater and hospital data and combine it together and monitor community and facility level disease risks. It can provide a snapshot of disease trends to anticipate potential patient surges. We can spot trends that may precede hospital cases. In general, that's usually what we see. We have a lead time. You can track the start of respiratory season to prepare for surges, and we just recently turned back on our subtyping. So you'll start seeing subtyping data for flu, and it can help also time vaccination and prevention campaigns effectively. I've talked to people who work in long-term care facilities. That can be a really sensitive thing of when do we give the flu shot. So this kind of gives us a good indicator of, okay, it's the start of respiratory virus season. We need to go ahead and give those flu shots. And then we can detect emerging pathogens early for rapid response, like measles, or whatever else 2025, 2026 throws at us, maybe all the way through 2028. We'll see. But anyway, I would love to take any questions.
Thank you so much, Abby. That was such a great presentation, and it has like been different, and I thought I was on top of everything your team was doing, but oh my goodness.
I mean, we change, I swear, weekly. We have like a new thing come up. So yeah.
Wow, very amazing. Any questions? I see Keith typing. Oh yeah, go ahead, Keith.
Hello, everyone. Great presentation. I just have a question regarding specificity. Could the uptick in Boulder with the sewer shed COVID virus be indication of uptake in vaccine?
That's a great question. I'm actually really glad you brought it up. So we actually can look for like vaccine types versus wild types, and we do it for measles as well. So what we see is they sequence it out. So we pretty much know it's wild type COVID versus like a vaccine derived COVID. It's the same with measles. We do have vaccine derived measles assay specifically versus COVID. We just kind of know from our sequencing. But yeah, thanks for asking.
Awesome. Thank you.
Yeah.
Are these samples done at the state lab?
Yes.
And how's the capacity look there? So it's great that you all have funding.
Yes. So we actually, a lot of our staff,
The test.
a lot of our staff is funded through ELC wastewater specific funding, which means that they continue to have a lot of funding. We have great staff over there. I think on our staff side, there's about 14 people in the lab that touch wastewater in some way. So we have a lot of capacity, honestly, for the amount of samples that we get week over week. But that is also why we are not doing 55 utilities anymore, because we had to be aware of that.
Great. Yeah, thank you.
Yeah.
Any other questions for Abby? Abby, so grateful you came out to share our information, as we will all be paying attention to those dashboards and acting accordingly.
And we're working right now just for local public health on creating reports that will go out every 2 weeks for you guys that summarize everything. And then that can be sent on to whoever you feel like needs to see it. So,
Which would be our friends
Yes.
in CIDER team for sure.
so yeah, we're working on that now. Yeah.
How does this information kind of correlate with the bug watch information that, Children's Hospital puts out? Is there an overlap? Do you find, this is a little bit obviously ahead of that, or?
So we haven't really looked to see if there's much of an overlap there. We usually, in general, just look at whatever clinical data is available to us. But because it is a community sample, like we do think we'll see it pretty quickly in a community. So we do think it probably provides a good bit of lead time.
Yeah.
But yeah, in comparison directly with bug watch, I don't want to say something wrong, but like I think we do have a great lead time on ours.
Thank you so much. So Emily Clancy has joined virtually. Welcome, Emily. And hi, welcome. Thank you so much for joining. And I know you said you couldn't stay till the end, so I think we're gonna jump in. And we were gonna do a quick presentation of our team dashboards that our EPI's created, but I think we're gonna go with Emily first and then go on to that. And I don't know, we'll figure it out. But Emily, welcome. Welcome to the Community Infectious Disease Emergency Response Team meeting. We have a lot of partners online and a lot of partners in the room, and we're so grateful that you are here to present. I think we talked earlier before Emily joined about the last health vulnerability assessment that we did. I think if we were to do a new health vulnerability assessment, which maybe we'll talk to Kristen and team, immunizations, vaccine preventable diseases, with what's happening on the national landscape, it seems like it's a ticking time bomb for us, for that to be the next several emergencies that we respond to and challenges that we face. So we wanted to bring in Emily to update all of us on what's happening on the policy stage in Colorado and beyond, to help us make sure we got our eyes on what's happening. Although Emily, I know it like changes every day. So I know that it's a tough presentation to share, but all yours, Emily.
Yeah, hello everyone. Can you hear me okay?
Yes.
Sounds good.
Okay, wonderful. Thank you so much for the invitation. to present to you all today. Yes, like Carol said, things are changing pretty rapidly. This is, I hope, an up-to-date version, but again, things seem to be changing daily. So let me go ahead and share my slides. Can y'all see that?
Yes.
Okay, awesome. So yes, my name is Emily Clancy. I'm the communications director with Immunize Colorado. We are a small 501c3 nonprofit organization. We cover the entire state of Colorado, and I like to sum up what we do by saying that we do kind of everything vaccine related except put vaccines in arms directly. We don't have any clinical staff. We're actually a pretty small team. We're a small but mighty team of 4. And we do a lot. These are our 6 core focus areas. They include coalition building, public policy, which is what I'm here to talk to you all about today. We work on providing free and low cost vaccines through community partnerships. And we do a lot of community outreach and awareness building, as well as provider education, data translation, and action work as well. I can share these slides out afterwards, so you don't have to read along, but this is just a basic overview of what we do as an organization. So before we kind of dive into the meat and potatoes, wanted to provide just a little bit of like background and context, some level setting. I think we are all aware that there have been a lot of shifts at the federal and state level in terms of vaccine policy. So in recent years, a lot of states, including Colorado, we've tried to take legislative action to prohibit vaccine requirements. So that's everything from trying to essentially make it easier for parents to opt out of school vaccine or requirements, and then also try to really make it harder for companies, hospitals, things like that to enact vaccine requirements. And we've seen this again across the country in a lot of different states. Some have been successful, some have not. Thankfully, in Colorado, we have a legislature that is really friendly toward vaccines, so we haven't seen that here. And then at a national level, in February, RFK Jr., who is a known anti-vaccine activist, was appointed as Secretary of the U.S. Department of Health and Human Services, and we knew that this would really be the start of some major challenges to immunization access and delivery, and we're seeing those play out at the moment. And then just some background, a couple of stats for Colorado: 88% of kindergartners were up to date on their MMR, measles, mumps, and rubella vaccine in 2024-25. And that's down from a multi-year high of 91.1 back in 2019. This is a trend across the country. We're seeing vaccine rates that are lower, have not returned to pre-pandemic levels, and are often declining. And then we've had 27 cases of measles in 2025, part of larger outbreaks across the United States. So really our vaccine rates are not looking great, and we're seeing resurgences of vaccine preventable diseases. So like a lot of our physicians tend to say, like, we are kind of a ticking time bomb, if you will. It's not a matter of if, but when we see these vaccine preventable diseases reemerge. Okay, so on to policy. Colorado passed a couple of bills this past legislative session. Our legislative session runs from January to May in Colorado. One of which was a bill run by CDPHE called Update Disease Control Statuses, House Bill 1027. And really in Colorado, we were really, I commend us as a state for being forward thinking in terms of a lot of the challenges that we're now seeing in terms of federal vaccine policy, and trying to protect against some of the things that we knew might happen. So this bill strengthens school vaccine policies by allowing the Colorado Board of Health to consider vaccine guidance from respected professional organizations beyond the ACIP, which is the Advisory Committee on Immunization Practices. That's the body that puts out the CDC vaccine recommended schedule. So it allowed the Board of Health to essentially look to organizations like the AAP, American Academy of Pediatrics, American Academy of Family Physicians, and others when determining school-required vaccination. A couple of other things this bill did, it extended the period within which a student whose certificate of immunization is not up to date to comply with that requirement from 14 days to 30 days. So essentially just gives parents a little bit more time to either get their immunization record in or a certificate of non-medical exemption in. It also extended the deadline for a school to distribute the annual letter to parents that shares their school's aggregate immunization rates and immunization requirements for the next year. So that was February 15th. It's now April 15th. So kind of just an administrative cleanup bill, but we also sort of snuck in this ability to point to AAP and others for vaccine requirements. And then Senate Bill 196, insurance coverage for preventive healthcare services. That bill really helps to safeguard, it does a lot of other things, but it also helps to safeguard state regulated insurance coverage for preventive services like vaccines. So that if federal bodies like the ACIP repeal or modify their recommendations, the Colorado Commissioner of Insurance can maintain coverage. And this really helps to maintain access to vaccines. So the caveat is that only applies to state regulated health plans, not to other health plans. But again, just some forward thinking. We're already seeing the ACIP modifying some of its recommendations. So this will be important as things move forward.
Emily, so this one hasn't passed yet, right? It's just a bill, not yet passed.
Nope, both of
And
these bills passed
Oh, they
this
did
past
pass.
legislative session. Yep.
Oh, okay, good. It's already
Yeah.
done. Cool.
Yeah. So again, kudos to a lot of our advocacy experts and our legislators for making sure that we were sort of being proactive when it comes to protecting vaccine access in Colorado to the extent that we could. So
Good.
yeah. So in terms of the national landscape, I mentioned the ACIP. They've really been the gold standard for vaccine guidance in the United States. The members that sit on that committee are vetted for many years. They are experts in their field, scientists, immunologists, people who have really in-depth knowledge of the science behind immunization. But RFK Jr. has purview over the ACIP. So in June, he fired all 17 sitting members and replaced them with new members, many of whom do not have expertise in vaccine-related science and research, and many of whom have expressed anti-vaccine views in the past. So right after he did this, the ACIP hosted one of their 4 quarterly, I believe it's 4, don't quote me on that. I think they have 4 meetings every year. But they had a meeting in June, and overall it was a deviation from the evidence-based process that ACIP has taken for decades. AAP, the American Academy of Pediatrics, often sits in on those meetings as an expert, and they boycotted the meeting and subsequently released their own immunization schedule. More on that in a minute. CDC staff were sidelined during parts of the meeting. They are often there to provide expertise, and they were essentially not allowed to do so. And then one of the recommendations that came out of that meeting was to cease use of thimerosal-containing flu vaccines, which goes against decades of scientific evidence that shows thimerosal is safe in vaccines. And there was no vote on COVID vaccines, despite being originally on the agenda. So again, a deviation from how things have been done and really not taking into consideration the evidence and the data. So just a little bit about the national landscape in terms of COVID vaccines. So in May, RFK Jr. unilaterally announced that COVID vaccines would no longer be recommended for pregnant people and healthy young children. That was unprecedented. No HHS secretary had ever done that before. It was not really in his purview. Usually recommendations like this have to go through, again, the ACIP, the formal process. And then again in August, or not again, but in August, the FDA approved COVID vaccines, but limited the eligibility for adults 65 and older and those with a high-risk health condition. The ACIP didn't make recommendations about COVID vaccines in their June meeting. They made them last week. And just as an FYI, that recommendation includes everyone 6 months and older, but with shared clinical decision-making, which essentially just means you have to have a conversation about the vaccine with your doctor before you can get it. But these kind of challenges left providers, particularly pharmacists and the public, really confused about who could get a vaccine, where, and what it would cost. I'm sure some of our public health folks on the phone or on the call got lots of questions from the community about this and are probably still getting those. So pharmacists have to look to ACIP guidance when vaccinating, and because there was no recommendation from ACIP, they ended up needing to require prescriptions. So that meant anyone who wanted the vaccine had to go to their primary care provider, get a prescription, and then bring it to the pharmacy, which is just a no-no in terms of vaccine access, especially for respiratory virus vaccines. We want to make those as easy to get as possible. I think over 90% of people get their vaccines, flu, COVID, RSV, at a pharmacy. So again, just a bad trend for vaccine access. And then vaccines for children, VFC stock relies on ACIP guidance too. So VFC covered kids couldn't get vaccinated before the ACIP made its recommendation, which really meant that kids whose parents couldn't afford the vaccine, can't pay for it, and are offered free vaccines through VFC didn't have access to the vaccines. So what did Colorado do in response to some of these challenges at the federal level? CDPHE and the governor's office issued a public health order and a standing order, which allowed all Coloradans aged 6 months and older to get the COVID vaccine at a pharmacy without an individual prescription. It did some other things. I'm happy to link to some of these things in the chat if you're interested in reading through the public health order, but that was the main thing that it did. And then the Colorado Board of Pharmacy held an emergency rulemaking hearing that removed references to ACIP and CDC guidelines, which allowed pharmacists to be able to administer the vaccine without a prescription, according to the standing order. And then a lot of organizations responded, not just to COVID, but to really the ACIP not taking into account evidence-based recommendations. So the AAP, ACOG, and AAFP have all released their own vaccine schedules, which collectively recommend COVID vaccines for all adults 18 and older, pregnant and lactating people, kids 6 to 23 months, and then kids 2 to 18 years who are at high risk for severe COVID. Oh, yeah. Yep. And this is all without shared clinical decision making. So again, we're kind of navigating, what insurance will look like, because insurance companies do have to rely on ACIP typically. But Immunize Colorado and all of our messaging is relying on these recommendations until and unless we can confidently rely on the ACIP again. So September, ACIP met again just last week to discuss COVID-19, MMRV, which is the combination measles, mumps, rubella, and varicella vaccine, and hepatitis B vaccines. And I'll just kind of go over what their main decisions were from that meeting. They decided to delay a vote on the hepatitis B birth dose to allow time for more consideration of the data. We were really scared in the public health world that they were going to repeal the hepatitis B birth dose. And so that hasn't happened yet, but that's only a temporary relief because it likely will happen at a future meeting. And then they recommended testing pregnant women for hepatitis B, which is not really even in their scope. So that was an interesting result of that meeting. They also recommended COVID vaccines for everyone 6 months and older, but only through, again, that shared clinical decision-making model. They did not require a prescription to obtain the COVID vaccine. So that's a huge win for keeping the vaccine accessible to those without a primary care doctor or insurance. Although in Colorado, we have that. We've done all of that work in the Colorado Board of Pharmacy to make that not a requirement anyway. And then they also decided to revoke their recommendation for the combination MMRV vaccine for kids under 4 years old. A lot of the meeting was spent rehashing settled science, and the MMRV decision was a result of that for sure. I will say that the AAP's schedule, they still do recommend MMRV for children under 4. So that's a deviation there. The AHIP, which is America's Health Insurance Plans, released a statement declaring that health plans will continue to cover all ACIP recommended vaccines that were recommended as of September 1st, including COVID and flu vaccines, with no cost sharing through the end of 2026. So that is a huge win for sure. So what's next? Again, it feels like we are sort of building the plane as we're flying it, so to speak. With all of this, but there are a lot of federal challenges to vaccine access, like we've talked about. So Colorado health and philanthropic leaders are really stepping in to fill the gap through a new coalition called Colorado Chooses Vaccines that will work on outreach and policy solutions to these challenges. So we have a statement of support. We welcome any individual or organization to sign on. I'm happy to put this in the chat, or Carol, I sent you my slides, so the link will be in there as well. And again, that group is working really hard to figure out, where do we go from here? In terms of legislative action for 2026, legislators are really fired up on this issue, which is wonderful. We've had a lot of legislators reach out to us asking how they can be of help. So there's already a bill title reserved for 2026 that can be used to support the policy solutions that are identified by Colorado Chooses Vaccines and Immunize Colorado, or Immunize Colorado's Policy Committee. And so we're really hoping that we can do some things to, again, continue to protect vaccine access here in Colorado. So lots more to come, but that is my presentation. Happy to answer any questions that y'all have.
Thank you so much, Emily. I see Keith has a question for you.
Yeah, go
Yes,
ahead.
thanks again, Emily. Great presentation. With state sovereignty being such a hot topic at the federal level, there was discussion about the Western Alliance, I believe it's called. Will Colorado attempt to join, or is this alliance to provide some, I guess, more states in this alliance to send a message to the federal government that this is important?
Yeah, there's definitely been talk about joining that alliance. I think that's something that Colorado Chooses Vaccines, the folks in that coalition are talking about. And it's definitely one of our policy options moving forward. I think there's a lot of complexity because, again, a lot of insurance requirements are still rely on the ACIP recommendations. But yes, that's definitely been, we had a summit a couple of weeks ago and got a bunch of experts in a room together. And that was one of the things that we talked about. So not sure yet, but it's a possibility.
Thank you.
I have a question.
Sure.
And maybe someone in this room knows it. Where are we with the BFC? Are we following the new ACIP? Or are we just following all the existing?
We just have to follow the existing.
Okay.
Federal.
So maybe no MMRV for anyone under 4, but we have to split them up for varicella.
Which is actually the recommendation. Anyway, it was possible if parents requested it as a combination to give that.
Okay.
But my understanding, Emily, those decisions haven't been officially signed off by Kennedy or the tech guru who is the interim leader, right?
Correct. Yeah, those recommendations have yet to go to the CDC director. Typically, the ACIP makes the recommendations and then they get sent over to the CDC director for sign off. But that has not happened.
Hence the reason the CDC director was. She wasn't going to sign off.
Right.
Yeah. Okay.
Dr. Meditz, Amy Meditz, I see your comment about IDSA. It might have come in when we were a few slides back. Was that about the vaccine recommendations from IDSA?
Well, she had listed a bunch of organizations that had made statements countering the Infectious Diseases Society of America, and Shay have put out quite detailed and collaborative statements as well. It just wasn't included, so I just was mentioning it.
Thank you. No, it's important to make sure, especially with the CIDER team. Okay. Thank you so much, Emily. So we will definitely get the slides and links out to everyone. And thank you so much for coming to present. And we might have to bring you back when the next legislative session starts or something. Yeah, next meeting, it'll all be different perhaps.
I know, right?
Thank you so much.
Of course.
And And so next we have one more presentation. And I think everyone is, familiar with the landscape that we're all facing with so many budget cuts and challenges facing all public health and health systems from the Fed level on down. And the challenges that we've had. I think this group sent letters of support to the county commissioners back when our funding got cut by a big chunk. And so we're always grateful for the support of this team. But I also am so grateful for Armando Guardiola, our new Director of Administration and Finance, who has engaged our agency in a process to for success and sustainability for the future, even though this landscape is so unpredictable and we've had so many funding cuts from all angles. So I'm gonna turn it over to Armando to share how our agency did all of this heavy lifting to make sure we don't go under, I guess.
Well, thank you. My name is Armando Guardiola. Like she said, I am the Director of Administration and Finance. And today I'm not going to go into the weeds. I don't want to bore everybody here, but I do want to kind of give you the framework, some of the landscape that the challenges, I guess, that we've addressed. And I believe I can see the light, at least as far as getting a budget done for 2026. That doesn't mean it gets us out of this challenge this environment that we're in. So I will talk slightly kind of what we did, why we did it, and then ultimately kind of give you a high level of where the agency's at. And then I do have Endura, and I thought I saw Lex.
Just
Okay.
I have to go to a meeting.
Okay, go ahead. That's fine. And I can kind of give you some of the minor impacts that we're going to be having. So, just a little bit to tell you a little bit about the history as far as the kind of the state of the union financially for Boulder Public Health is. Last year, around 2025, we were building a 25 budget, and we worked hard to really build a more actual and not an inflated budget. We've had an inflated budget for a couple of years. I think every agency, every organization that had any money coming in from COVID or were COVID, expanded in 2020, 2021. But it's very difficult once you ultimately expand to kind of shrink and reduce, right? It's not as easy as everyone thinks it is. It happened. If it was, then most agencies probably wouldn't be in the boat that they're in or that we were in. So we did a quick, small reduction in 2025, doing the 5%, trying to be very mindful. I was fairly new. I didn't want to make too many enemies, but we did a 5% decrease on operations and try to really just balance the budget to be more in line with the actuals. So that was a $1.5 million reduction. We still had a lot of grants, but we knew that we had some systematic in alignment within our budget, some deficits, but we got a budget that was adopted. So very proud of the divisions. And thinking that all we were going to do is kind of just start cleaning up the budget. But then January, as you hear the environment, we got hit with the feds holding on to a lot of the federal funding, the unknowns. 25% of my budget is based on the federal or state pass-throughs or state grants. So that was a challenge. And the last thing I wanted to do is be very reactive. So what we ended up doing is I talked to our executive director and I got the board on board or on their support to actually move towards priority-based budgeting. If you all know what priority-based budgeting, I'll give you a quick, is really aligning our priorities with our resources and funding. Not easy. A lot of organizations fail because they lack, I would say they lack the holistic view of looking at an agency holistically. We tend to be very siloed, and that's in every organization. So I don't mean it in with any disrespect for public health ourselves, but that was the challenge. So we started this right around January, building some tools. We built a bunch of cool tools. We tested them. Some worked, some didn't work. But ultimately, it was really a collaborative effort trying to empower the division managers to put some skin into the game and really letting me know what is the best way to to one, reduce, right? Right size the agency because we had a deficit because of COVID. That was one thing. And then ultimately the deficit that the environment and funding that we're in and we're currently in, it's nonstop. And so how do we address that? So we use that, we built some models. If y'all want, I can give you the details, but today I'm going to go high level tools that we built. They went out and every division came out with, we received 268 recommendations of how we can reduce. One of the things that I did do prior to actually sending these tools out for them to work with was I did a 10-year, it was actually 11-year financial analysis and trending on the organization. I don't think it has been done in a while because just from looking from COVID, I think everybody was so busy. So I looked at the financials and I did an 11-year, and then I also did some inflation and then CPI inflation trending to see where we should be as an organization if it was perfectly, streamlined, trend after year, year after year, compounding, and did the inflation factor. So I came up with 3 target scenarios. The cool thing is, one of the target scenarios was really in line with what we got cut if we was to lose all our funding, which was at 25% in federal funding. So that was a target. So those were the 3 targets we gave each division, and the targets were anywhere from 10 to 16, a 20%, and then a 25 worst case scenario. The reason why we did that is I wanted to be able to react when we lose funding, because what I started doing in January, we were like, a fire, we were like trying to react. We didn't know what to do. I think we were getting the division managers, stressed out. They were like, what are we doing? We're not going to have this. Everybody was like 25%. So what really actually happened is we lost very few. At first they were just holding on to the funding. But we've had a lot of that funding coming in. I watch that on a monthly basis. So funding is coming in. I think more the challenge is next year. What are we going to get next year? So that's really where we're starting to look at now. But we have these mechanisms in place, these leverages that I know if we lose this funding, then we already know we have these recommendations I can pull. So a little bit, I mean, it's not ideal and it's not where I want to be, but I feel that we have control of the budget as far as, how do we address these deficits instead of reacting and maybe making bad decisions because you don't have enough time to analyze, do the trending. So it does give us some breathing room, right? So we've been doing this for almost a year now. It's not easy. The hardest part is culture. We had a meeting last week and division managers weren't happy with some of the changes. We knew that was going to happen. We've been trying to communicate, being transparent. As much as we can. They probably hate hearing priority-based budgeting, but that's what it is. We called it, I think, sustainable future, trying to tag it differently just so they can feel a little bit more comfortable. So presented to the board. And so I'll talk a little bit about what we're presenting, and then I'll talk slightly about some of the reductions and the impact. So we presented to the board in June, end of July, and the commissioners with a 16% reduction. It's a lot. It's almost $3.8 million reduction in our budget. Right now, I'm still about 700 over that. We're still looking at additional reductions. That includes 30 positions. We're very strategic on the positions. We use a lot of vacancy savings. So that means, we had a vacant position, we're not filling it. So the attrition part of it, if someone left, we didn't fill those positions. We did have some layoffs, very minimal, 10 that really affected people. We did have a lot of term positions that will be sunsetting as far as, when funding goes away. We built policies that kind of protect us with that. So some of the things that we've seen with COVID is we kept people longer than the 2 years that we originally maybe anticipated, which, the funding was coming in. I get it. I understand. It's hard to get rid of somebody, but they're contracted in their terms. So we're sticking to that policy. We've also looked at fee programs. So we have programs that rely on fee, but we are still subsidizing a lot with our general fund from the county. Done a lot of the analysis trying to get to a good place to say, this is reasonable, this is sustainable. We're government, we understand that, but we shouldn't be subsidizing more than, we have, I think the most we have is the 33% one, in trying to right size those. So we looked at those type of programs. How do we right size those to be a little bit more efficient? And then ultimately I took flexible funding. So I identified all the funding and put people, or we're working on there now, but at least getting an idea where people need to be at, so I can have some additional flexible funding for programs that don't have any funding. That's still a challenge. We have programs, so we identified every single program. One of the tools was inventory. So we took every single program that we offer at Public Health, and we either categorized it with infrastructure, which is like your HR, your personnel, your finance. We did mandate, which is mandatory. We got to do it. There's no ifs or buts, but we have to get some funding in non-mandate. So at least every position is categorized. I think we need to improve that next year, looking at some of the essential positions. That's a little bit more tricky, because some of those don't have any funding. So I have to address programs that have no funding, and no funding that we anticipate coming in for next year, a reduction. So that's still a challenge, but I have at least reserves to be able to maybe one man size these positions. What I'm trying to do is this model where I don't eliminate a position or a program, because once you eliminate a program, it's very hard to get the program back, right? So there might be some skeleton crew programs these next 2 years, but I think what I presented to the board is sustainable with our reserves that we've had for the next 2 to 3 years, anticipate, without having any additional cuts, right? Very small, maybe attrition would be the only thing we look at, or programs that or lose grants. So we presented a $20.6 million budget. I still got about 700 to cut to the commissioners. But what I do want to talk about is that it did affect CIDER. It affected all our programs. It affected my infrastructure. So with that, I think we are in a good position as far as to go in and try to adopt and sustain the programs that we have. Are they going to be smaller? Yes, they are. The one thing that the commissioners have asked me that I don't feel comfortable, or I don't think that we have enough data is the impact on the community. With the reduction, I believe there is going to be impact. But I think we need to be careful, and I say it in this room, is it doesn't, you don't have to be a scientist to know there's going to be an impact, but what impact, I don't know. I think we have to really take next year and look at what, hopefully have the right either KPIs, metrics, operational metrics in place to be able to really assess that, because I think that what's going to be important for the public, for one, and then ultimately the commissioners who have to hear these constituents, right? To say, hey, I used to get a vaccine, every Wednesday, and now I can only get it, once a year. Just giving some examples. So those are the impacts that they want us to explain, but we don't have that. So I'm real careful. I know there's going to be impacts, even within just your infrastructure. For example, I eliminated a program or a contract and a procurement purchasing individual. We had 5, we went down to 3. So that means I believe that service level should be the same, but there might be an impact. So I'll know next year as we start trending that to see, what's the impact. So a lot going on, but I believe the direction that we're heading, I'm trying to sustain this organization and this agency for the next 3 years. It's not ideal. It's not the position that any finance director wants to be in. But I think we've put a lot of work into it. The division managers have done a lot of change management, but that's kind of where we're at. So I gave you a real highlight. I mean, there's going to be, I think y'all know the Rise magazine that you sent me, Carol. We got selected. So there'll be a piece out, I think, next month on kind of our case study with priority-based budgeting. So if you have any questions, I open it up. I don't know if y'all have any questions for me. Thoughts? Maybe any money, but I think everybody does.
Well, and I can say that, as far as CIDER, so I'm Stephanie Farron. I took over about a year ago for Indira as the manager of the CIDER division. And this whole team, all of the programs with CIDER worked really hard to identify how to, I think, like Armando said, right size, so that we can keep this work, which is real core essential public health service work, continuing. one of the changes that we are having as a division is that the immunization program is moving under Carol in the communicable disease program. So both of those programs will be together, which, you know, they've worked together. And it was a plan actually before COVID. So this is kind of going back, and that was something that we talked about a lot, was sort of right sizing and looking back to pre-COVID, if anybody could remember what that looked like, right? And so that move happened, or will happen in January. We have lost a couple of, or will lose a couple of immunization program staff, but our nurses will continue, which is wonderful. We've lost some administrative help. Our epi team is staying intact, and our emergency management team is staying intact. So even though there's been quite a lot of movement and a lot of changes in some of the other divisions, CIDEM has really been able to stay pretty well intact with staff to provide services. So, it will be different. I know Armando is going to be talking to partners that work more with some of the other divisions as well. And, they are having bigger impacts probably than some of us. But I think we feel pretty confident that we can continue to do this work. And so.
Yeah, we're just so grateful that this process was very systematic.
Yeah.
Very thoughtful. And, seeing our counterparts and our colleagues in other LPHAs or at the federal level, like just from one day to the next, like just kind of big cuts happening without any warning. I think our agency was able to engage in a very thoughtful process. And like Armando said, that we have some unknowns.
Yeah.
Like, for example, our team, Ming and Stacy and Nick, our EPIs are going to be taking on this one grant that's part of the MUGSI, ESBL, and invasive E. coli surveillance. And that grant, it's chart reviews, and you have 30 days to do them. So we're like, well, we should be able to, sneak those in between all the other cases that have to be done immediately. But we don't know, and it's possible that next year we have a lot of emergencies that then don't allow us to get to that ESBL work. And then we'll maybe have to figure out and pivot. Like those unknowns are still out there too, but we're going to try it. We're going to try it. We're going to bring those on, maintain that really important surveillance program that we get a little bit of funding for, because we never get enough funding for all the stuff we do, but we'll take whatever funding is out there. And yeah, there's some unknowns, but
there were two very, significant grants that were still COVID related, the ELC funding and an immunization program, COVID fund that, basically, well,
yeah,
it was just like everybody has mentioned, one day it was like, we got the money, go forward. Literally the next day, nope, you don't have the money. We're taking it all, and we're taking the money you haven't spent yet. I mean, it has been quite a ride the past,
A roller coaster.
Yeah, it sure has. We're all just like holding on.
yeah.
But I think again, like Armando said, we're in the best place I think we could be, moving into a position, into a situation that is just completely unknown. I mean.
Yeah, and I will say for our, partners like BCHCU, this is an important discussion, right? So clearly all our systems are being impacted. I'm sure I can only imagine some of the conversations y'all are having. So, with care and, impacts to higher education. So it's important for us to continue these conversations together as we rebuild these systems.
Yes.
And for me, it starts at this level because this is where the work gets done. So I think it's important to share this today and let you all know where we're at, what we're prioritizing, really looking at the central work together that impacts the community. Now's the time to really have those important conversations.
And there will be more kind of broader communication out to our
Yeah.
partners and out to the community. But since we had you all here today, I figured it was just a really nice opportunity to be able to tell you kind of what was happening. So when you saw the stuff come out, you're like, yeah, we know.
Yeah, we're working on communication that goes out to all the partners, kind of laying out, as far as kind of the minimal impacts or as much impacts that we can provide. We don't know a lot of that service levels, but we just wanted to kind of highlight kind of where we're at. So, yeah. See, you did get 50 million for Matt Schultz today. I saw that on the news. Did you see that?
Oh, for Manshoots for the,
I don't know what it was. I saw CU something like,
yeah.
they got 50 million is what I see for mental health.
Yeah.
I think it was, yeah. Well, thank you. If you have any questions, welcome to send me an email. Anything on the organization, please. I can do. Thank you.
Reading the room, that's probably not a good time to go into dashboards. That we're gonna share with you. We're not gonna do that to you because like I know the troubles are probably starting to sign up. But we
Sorry, I didn't mean to be that boring.
But I'm super proud of our team, Nick, Stacy, and Celine for launching our dashboards. Can
we see it?
I guess.
Just like show them and not do it.
See that? Yeah. Like, oh, we don't want to show you our dashboard.
I was just gonna ask. how
Like Power BI, because I know Power BI.
State
It-
or
Maybe
obviously.
some of it's presentations, but
But as
definitely
far as
different
like.
than how, yeah, more like actually
Has
coding.
that really been a big
Yeah.
impact as
Cool.
well, like just people and programs, Food Net and all.
Well, yeah.
Yeah, I mean.
Yeah, I don't have a reading on the impacts to CDPHE yet.
okay.
I know they've had several cuts,
Yeah.
but I think some of it was that like, the cricket team for long-term. That work already moved over to us over 8 years ago, but they were still like there supporting. But then I think a lot of that team is now no longer getting for COVID funding.
Okay.
For our other teams that we work with really closely, I think they're all still there so far.
Yeah.
It really has been like almost day to day. You hear, oh, these folks are getting cut. Oh, they're cutting more people. And
Yeah.
it's like, oh, it's
Yeah.
scary. Very,
Yeah.
very scary.
Well, and the CDC did say they're no longer going to take surveillance data for most food net pathogens, only Salmonella and S type going forward, but we're going to continue
Yeah.
to do all the disease investigations and putting all the data into EpiTracks. But maybe one day someone will come to CDC and they'll want that data retroactively to be able to, produce trends.
Yeah, I just wondered if like the, kind of the CDIM portion in a way
Yeah.
of the state, are
Yeah.
they taking that same approach of like trying to at least provide coverage or,
I
or
think-
continue?
Well, it's too bad that Fondo left. I think
Yeah.
what we have heard is that it has not been the same process as we have gone through. And like Armando mentioned, he has been now invited to a couple of different organizations to talk about this process. And I've been in a couple calls with folks from CDPHE where they have been very surprised at the, real methodical system that we've been through.
Yeah.
And the input, because all of the input has been from the programs. Or 90% of the input has been from the programs, I would say. And I don't think that that's happened at the state level.
What's that?
Yeah.
Yeah, kudos to you all.
And kudos to Epi team for
Yeah.
launching our respiratory surveillance ahead of schedule.
Yeah, so I updated this guy last week. This one was launched last winter, I think maybe February. Prior to this, we had a different respiratory illness dashboard that was done in Tableau, but with funding cuts. We pivoted, and so now we have to rebuild the dashboards in R. So this one was kind of like we have like the COVID Tableau dashboard before I was here, and then I think we pivoted over to like more respiratory viruses dashboard, and so I translated the Tableau version into R. And this is pulled from our syndromic surveillance data, so it comes from our hospital partners. We have one that goes over our hospitalizations. It goes back the last 2 years. So from like year to date now to 2 years prior. So you can kind of see trends. Those different lines indicate different pathogens or diagnoses and how they're based on how they're coded at the hospitals. And then the other dashboard is just our ED visits. So it should coincide pretty closely, like the peaks and things like that. But it's based on individuals that are seeking care versus severity of disease, which is what we use like our hospitalization data for. So yeah, this gets updated. It is. And the first one, sorry, Nick, to have you go back, but there is also a little like data lag line that you can see that's built in there. It's that red line. So anything after that red line, it's not really like reliable data yet. But then once it gets past that point, that's when we have that more reliable data come in. I think that's really it.
Updated weekly on
Yes, on Mondays, unless there's a holiday on Tuesdays.
I can go into the Tarek dashboard really quick. A lot more tabs going on, but also because of money in Tableau, we transitioned to R for the Tarek dashboard. So we launched it, I think, in July, so it's very new. And it has a couple more features than our old dashboard did, but it goes over the yearly case count of enteric diseases by pathogens. We added more pathogens, so we have all the reportable enteric disease pathogens on this dashboard. Previously, just had a couple that were more common. In Boulder County, we have this table that's interactive. You can interact with it, and it goes all the way back to 2020. Then we have breakdown by sex, ethnicity, race, hospitalization, and age. And all this is interactable. So you can go and see the percentages for each group as well. And then this is broken down further by each disease. So for our diseases that are most common in Boulder County, where we see the highest incidence, we have a graph of 2024 to 2025 compared to the previous year. And then this red dotted line is our 5-year average, which is taken from 2019 to 2023. Keep in mind that was also during COVID. So enteric disease reporting was could have been down or up depending on what was going on at that time. And then similar demographics just into each specific disease. The only thing that's a little bit different is when you get to cyclospora and vibriosis. So since we don't see these diseases as much, we didn't want to break it down by each month in the 2025 and 2024, just because we didn't want to run into the risk of accidentally identifying who those people are in the community. And so we just have a graph comparing each year to each other, and that dashed red line is the 5-year average before 2025, so 2020 to 2024. And again, similar demographics. But yeah, that's the enteric disease dashboard that we just recently launched a couple months ago.
Awesome, thank you. And then we're working on a vaccine compatible dashboard. That one is in the works.
And possibly a zoo dashboard as well.
Yeah, so.
Possibly a what?
Zoonotic disease vector.
Yes, for the zoo.
That's how it feels to work.
Yeah. I think that was a much better end to the meeting than.
Yeah. Thanks. That was much later. So we are at the end of our meeting, and I want to thank everyone for coming, and we'll keep engaging, keep getting ready and connected for whatever comes our way next. And we'll be meeting again soon, I'm sure.
Thanks, everyone.
Yeah. Thank you. Thank you.